day. Some of you did it this morning. Actually, we held this end of life early day. I think this is probably one of, although everything was very interesting, this is the one that usually grabs most people's attention. And we did touch on it a little bit when Christy spoke, but we're going to get the in-depth end of life story. So Deepthi Rajeev, as a PhD, her doctoral research is in biomedical informatics, focused on enhancing the communication between public health departments and healthcare facilities to improve the timeliness and completeness of public health disease reporting. And then I'm going to let you talk about that more. What Deepthi's been involved with really since she came to work for HealthInsight after she got 2 master's degrees and a PhD is working on this end-of-life project and also the public health reporting component, which Jeff, who's going to speak next, works for New DOH. A little brief synopsis. I have way too much information on both of you. And Jeff is the Public Health Informatics Program Manager at the Utah Department of Health. He's been there 17 years. He was a statistician and director of the Office of Vital Records and Statistics, where he oversaw the development and implementation of information systems for the management of births, deaths, and other vital records. So he has also been doing the technological component of the whole POLST. So you could fill in the gaps on this, both of you. I'll let you go.
Thank you, Heidi. So Christy gave us a brief introduction about the electronic physician order life-sustaining treatment project, and this was under the Beacon grant. And so I will talk about, if I can make this work, I don't know where to point. So I will give you a background on why we think end-of-life care documentation is important, and Jeff will talk about the design and development of the POLST registry. And finally, we will walk you through the POLST registry. We'll give you a live demo, so we'll actually pull up the site and walk you through the site. And then we will also show you a POLST video that we took with our actors. We didn't hire actors. We had our IT team pretend to be actors, and they did a really good job. They were nominated for the Oscars. So we'll show that video, and it's gone viral on YouTube. So, and finally, we will end with questions and answers. I don't know where to point. It's like, okay. So, over the last few years, there's been an increase. The healthcare has improved. There's an advance in medical science and technology. And thanks to the public health surveillance and investigation and immunizations, there's been a reduction in infectious diseases, deaths due to infectious diseases. And so right now, the causes of death is no longer infectious diseases. It's heart disease and cancer. And due to this shift in the causes of death, the US life expectancy is increasing. So it's estimated by 2050 that men and women would live until 80 years and 83 years. And what does this do? So when you have people living longer, you're going to increase the population who would need palliative care services and end-of-life care services. So this is becoming a really hot topic now. And there are several phases of life. So you are born, and then you have your infancy and your terrible twos. And I have a 2-year-old right now, so I empathize with that. And then you go to preschool, you go to kindergarten, and you go to college, and you have you can start drinking. And then finally, you get your job, and then you become an adult, you have children, and then you have grandchildren, and then finally, you start having your platinum years and old age, and it's like a full circle. And then finally, you die. So death, the point I want to make here is people they think death is a taboo word, and I want to say that death is just a phase of life. You go through all these phases, and death is just one of them. So don't get scared to talk about it. Talk about it because everybody is going to die. And I have a 5-year-old who asked me, what is death, like a couple of months ago. And I was like, okay, how do I explain death to a 5-year-old? So, but you have to talk about it at one point of time or another. And you can't skip this phase. We're not mortal. So we are not immortal, rather, we are mortal. So everybody has to die. So you rather talk about it and be prepared for it. And what's important is that you need to empower patients or people who are in their final stages of life to make the decisions. Some people might want to die in a hospital because they had children and they were really well taken care of by the nurses, so they just have a really very nice vision of dying in a hospital. Or some people kept going to the hospital and they just don't want to go anymore and they want to die at home. So don't assume what people want. You have to empower them and give them the right and the tools to make the decision and document those decisions. And how do you do that? You have to have a conversation. I have no idea what my family wants. I have 2 parents in India, and I have not had this conversation, honestly, with them. And I don't know what they want, and they don't know what I want. So you need to have a conversation, and this conversation includes the family, the patient, and the provider as well. But then, when you want to have any kind of change is hard, as we have heard in the previous presentations. So when you discuss death, you go through these different phases. If you're talking about you talk to my 2-year-old, she has no idea. She thinks you're immortal, nobody dies. But then you have this denial, and then there's distant acceptance, and then finally you accepted that, okay, I'm mortal, I need to plan for the way I want to die, and then you start preparing for it. And what does the preparing require? So you decide, okay, how do I want to die? Where do I want to die? And then there are several resources. So the Living Well Coalition is a group of people from the community who want to improve the conversation and improve general awareness of end-of-life care issues. So they have really good resources that would help people in that specific stage. And you also have other resources like the closure.org and the Conversation Project. So there are several resources out there that help patients talk to the providers and give them tools to improve their conversation and have the conversation about death. So we talked briefly about the advance directives, which is referred to as the living will. So I wanted people get confused about the physician's orders for life-sustaining treatment and the advance directives. So I wanted to bring about the difference over here. So the advance directives is for anyone. Anybody in this room should have an advance directives. And the reason you want to have that is if you go out on the street, you get hit by a bus, you want to say, okay, this is what I want. If I'm not breathing, I want to be resuscitated. And typically, you would want to be resuscitated, and because you don't have a life-threatening condition at that point. And then it's for a future event. You have not been diagnosed by a chronic illness, and you don't have any life-threatening disease, but it's just for a future event. So it's not medical orders. And the reason why the advance directives came about was in 1990, there was this Patient Self-Determination Act that said that all healthcare facilities getting funds from Medicare and Medicaid should have some kind of process that would allow the patients make decisions for their treatment. And everybody thought, oh, the advance directives would just fill this gap. But then there were lots of studies that said, oh, that specified that it didn't really fill this gap because it's not medical orders. So people were not really complying with what's written in the advance directives. And it's self-directed, so you don't really need a provider to sign. So I can fill out an advance directive and just sign it myself and maybe have my neighbor attest it and say, okay, witness it and say, okay, these are Deepthi's wishes. And so I don't need to include a medical provider. The POLST, on the other hand, it stands for the Physician Orders for Life-Sustaining Treatment. And this is for a very specific population. You need to either be frail, and we were talking about what's the age limit. You need to be over 60 or over 70. But typically, if you look at the legal documentation, it says frail. But it does not really give an age. And then finally, you have to be seriously ill. You should be diagnosed with cancer or a life-threatening disease like that. And then it's a legal form. So if the healthcare providers looks at the form and they comply with your wishes, they are legally protected. So they cannot get sued for complying with the wishes in the POLST form. And then finally, it's a conversation. You cannot fill out the form by yourself, or the provider can't give you the form and say, okay, go fill it out and bring it back, I'll sign it. He needs to have a conversation with you, and it's a very tricky conversation. When you try to elicit patients' preferences about how they want to die, it's not going to happen in one conversation. It would require at least 3 or 4, it would require a series of conversations. So, and then it becomes part of your medical record. I'll show you the POLST form. So basically what happens is the providers have these conversations, get the patients to tell them their preferences, document it, sign it, and then it's scanned and it becomes a part of their medical record. And ultimately, it's a gift to one's family. We've heard so many horror stories where it goes either way. Sometimes the patient has a POLST form, but then they have not been found. That's the story that Christy told us earlier. And then they are resuscitated, and then their quality of life is not the same. Or the other, I had gone, recently I'd gone to California, and I was talking to a pulmonologist. And so he was telling me, I was telling him about my work, and he was saying that he comes across this every day, where people do not have a POLST form. And there was this one case where an elderly person didn't have a POLST form, and he went into a coma. And he was in a coma for 4 years. And then the doctors kept saying that we cannot do anything, he's not going to come out of it. But he didn't have a POLST form, and the family said, no, do whatever you can. So then they found out that, I think in the year 4 or 5, he realized that the providers realized he needed surgery. So they performed surgery on a person who's in a coma. And this is a true story. So then finally this doctor I was talking to said, I cannot work on this case anymore. So he was taken off the case, and then somebody else was taking care of that man. And he just, his head literally burst, and that's how he died. And because his family did not want him to die. So if he had gone about specifying his wishes and saying, okay, if this happens to me, do not resuscitate me, do not put me on life support, his quality of life would have been so much better. So this is ultimately this is a gift you can give to yourself and to your family. And then the POLST paradigm was started in Oregon in 1991, and it basically translates patients' end-of-life care wishes into medical orders. And if you go to polst.org, you'll find out that it's endorsed by 15 states right now. And in Utah, the POLST forms were authorized under this Utah law. And there are about 32 states that are in the process of developing POLST programs. And finally, it should be a tool to initiate the end-of-life care conversation between providers and patients and families. And right now, it's of those 15 states, it's paper-based in most of them. And so when you talk about a paper-based form, so this is the paper, oops, sorry, hope it works now. I'll go back. It's not working. Maybe I'll just move there.
Yeah, that one should be.
Nope.
Your little arrow right here.
Okay.
There on this side.
All right. I'll move this here. I wish I had glasses. So this is the POLST form in Utah. So as I was saying, it has to be, so every patient has a POLST form. So you have the patient name and the date of birth. And ultimately, you cannot do it without the provider. So it's associated with the provider as well. So you have the provider's name and the phone number. And there are about 6 sections. So if you've heard of the do not resuscitate form, which is the DNR order, so this, in section A, the information in the POLST form covers the DNR information. So if you have no pulse and you're not breathing, do you want to be resuscitated or do you not want to be resuscitated? And in section B, you have, okay, when you have a pulse, what kind of treatment do you want? Do you want the full treatment or do you want only comfort measures? And then section C says, okay, I want antibiotics, I don't want antibiotics. And then ultimately, it talks about the fluid and the nutrition, and then this one. It talks about who did you discuss this when you filled out the form, who was present, was the provider present, who else was present? And then you have whether you have an advance directive or not. So the POLST form does not replace an advance directive. It's targeted towards different populations. And then here you have the signatures. So if you're filling out a POLST form for a child, you would need 2 signatures from the 2 providers. And then, so there are several situations when the POLST form can be updated, as we were talking about this when Christy was talking. So a POLST form has to be reviewed when a patient is transferred from one healthcare facility to another, or if a patient's health status changes substantially, or a personal life status. So if you get if you've been diagnosed with cancer, but then you have a new grandchild, or you get married and you just want to live longer. So there are different situations when you would want to change your preferences. And as we were mentioning earlier, when you change your preferences, make sure you have a new POLST form, because the old one gets deactivated and the new one becomes active. And when you talk about that, you don't have any systematic processes when you're trying to do version control for paper. So the current process has this huge disadvantage. So if there's a 911 call and an EMS provider goes home and he sees a POLST form on the fridge, but he has no idea whether that POLST form is the most active one, or there is a more recent one, but it's hiding somewhere in a drawer. So then you need to have some kind of systematic processes that will allow you to say, okay, this is the most recent form and this is the person the form relates to. And then finally, it needs to be accessible at the time of need, because we talked about that lady in the church, so it was not accessible at the time of need. She did the right things. She went through talking about it with her provider, she had a conversation, but then she filled out a POLST form, but then it was not found. So and then it has to be accessed by multiple users. So the providers in the emergency department should be able to access it, as well as the EMS providers, and there are other people as well. So the electronic POLST was funded by the Beacon project, and it was funded in 2010, and it was a collaboration between the Utah Department of Health and HealthInsight. And our goals were to improve consistency between the patient's preferences for the care that they wanted at their end of life and what they actually received. So right now, the congruence between the patient's preferences and the treatment that the patients receive is very low. So we wanted to improve that congruence. And ultimately, we wanted to do that by creating an electronic POLST registry for use in Utah. And so there are, as I mentioned, we had 15 states, and of the 15 states had the POLST paradigm. And of those 15, 3 of them have Oregon, West Virginia, and New York. And they have an electronic POLST registry. But in Oregon, they have paper POLST forms that are manually entered and then sent to the registry, and then they have data entry people entering the information. So it's not really electronic, because the input end is not electronic. And then also the access end, when the EMS provider wants the information, they call a 24/7 hotline number and say, I have this patient, this is her address, date of birth, what are her preferences. So you can see the time lag when you're talking about trying to provide CPR. If you provide CPR within 30 seconds, I think the probability of their coming back to their same quality of life is higher, as opposed to if they're resuscitated after 30 seconds, then their quality of life, there are higher chances that their quality of life would be reduced. So time is really important, so you really need to have timely access to these forms. And then West Virginia also has a paper process to create provider accounts, but they do have an electronic registry. And New York has an electronic. So some people call it the POLST, some people say MOLST. So the MOLST is basically medical orders for life-sustaining treatment. Thanks. And so Jeff is going to talk about our Utah ePOLST registry design and development. And I'll let him talk now. Oh, sorry. You might need this.
Okay, so I work for the Utah Department of Health, and HealthInsight approached us a couple of years ago to develop this ePOLST registry. And so you might think, I was in vital statistics for years, and we do birth and death certificates and marriage and divorce. And so within the health department, they said, well, this should go to vital records. So you might ask, why vital records? Why is that a natural home for this type of application? And we have an electronic death registration system that we developed in 2006 that replaced the paper death certificate process to a large part. Physicians, when a person dies, a funeral director rather, will take the deceased person's body, and they'll collect a lot of information, and then they have to track down a physician to enter the cause of death. And in the electronic system, all the funeral directors just immediately, they wanted to use this web-based system to register deaths. We spent the last 6 or 7 years just trying to recruit physicians to do that. And a lot of them want to do that, and a lot of them don't. A lot of doctors only sign maybe 1 or 2 death certificates in a year. So they didn't want to get a login to a system that they rarely ever use. But we have about these 300 physicians that do the bulk of deaths in Utah. They use our electronic system, and it turns out they're the same doctors that see these types of patients in end-of-life situations that have POLST documents. So one huge advantage is that we can leverage our work with doctors to get them to use POLST, the same doctors that use our Eden system. Another advantage is we can purge the registry, because when we first talked to Oregon, when we started this effort, we found out that was an important consideration, was keeping the number of active records in there as small as possible would help with the speed and the confusion that might happen in an emergency situation. So the other advantage of linking with the electronic death certificate and with our death database is that when the person does eventually die, we can purge their, not necessarily purge their record, but inactivate it in the POLST registry. Like I said, we talked to Oregon. They were, at the time we started this, Oregon was the only one that had an electronic POLST registry. So we got on the internet, we identified some people. They spoke with us on the phone a couple of times. We learned a few things from them. The fact that they used paper, and Deepthi already mentioned that, we didn't want to use paper if we could get away from it. We wanted a completely electronic POLST. And they used a 24/7 call center at Oregon Health and Science University. And I'm not sure how they funded that, but it was pretty obvious to us from the day one that we were not going to have money to support a 24/7 call center. So we had to do something else to enable searching our registry. Is this the right? Okay. Well, there we go. So the first thing we did to start this project is the first thing you do in every government project, probably private sector too, you form a committee, right? You get a bunch of people together to talk about it. And so that's what we did. We had representatives from Vital Records and Statistics, Bureau of Emergency Medical Services at the Utah Department of Health. They cover all the licensing and the rules and regulations for EMS providers. Commission on Aging, they had kind of a leadership role in this process. And physicians and staff. We were able to get some physicians in these end-of-life practices, hospice, palliative care, nursing homes, the physicians and their staffs that deal with these types of patients. And we started meeting in 2010, and we're still meeting now, and we're still moving this project forward. Okay, so this is an overview of the ePOLST architecture that we came up with. It's fairly simple, and it's similar to our Vital Records web-based applications. We have our Eden system at the top there, and then we have our ePOLST database. And early on, we identified 2 really broad use cases for this thing. There's the management use case. It's the putting in records and managing patients and their preferences, and physicians signing these things. And then there's the search use case, typically in an emergency situation when EMS or emergency room providers need to search the registry to find out if a person has an active POLST and what their preferences are. So it's hosted in a Linux, Apache, MySQL, PHP environment at the state data center, at the state capitol. And there are secure transactions between the two for the 2 use cases. On the input side, physicians have to sign these things. They're physician orders. And in some cases, well, I think for ePOLST's advanced nurse practitioners can sign them as well. Social workers typically do this work, though, or nurses. They have the conversations with patients, and they go out and they talk with patients and their families, and they get, they document what the patient wants in their end of life. And then administrative staff go in and handle things too. Okay. So as far as project development, since this is a project development conference, I didn't want to get up here and say there was none, but we had a lot of constraints. Again, we had limited budget. We didn't know the scope of this thing, and we had some time constraints because of the funding. So we adopted this sort of agile approach where we had some discussions in our committees, and we hashed out these requirements. And then we did contextual interviews. We went out to the sites. We went to a couple of fire departments and talked to the EMTs and learned how they worked when they visited, when they went to a home and had an emergency and they had to find a POLST. We went to nursing homes and talked to nursing home doctors and nursing home staffs and found out how these paper POLST documents were filled out and how they were put in charts and where they were left. And hospice doctors, they had a different use case entirely. They and their staff go out to patient homes and collect these things. And so we identified a lot of different environments these things are used in. We even went to Primary Children's Hospital. It turns out there's a fair number of children that are terminally ill that get these things. And so each one of these has dramatically different requirements as far as electronic systems go. How do you input the data? What do you do if the input's at a patient's home and they don't have Wi-Fi, for example, or a printer? What's the role of a paper document? Like I said earlier, we really tried to get paper out of this process. So we did this iterative process where we would discuss some requirements, and then we had a programmer, and we would develop a sort of a prototype, and then we would demonstrate and talk through those issues again, and we just kept building it in that fashion. So, and that's where we're at today. Today we have a almost fully functional registry. We've done some pilot testing. We're just working out the final kinks, and we hope that very quickly we are in full operational mode. And I'm actually going to walk you through the system right now and show you what it looks like and some of the key features that it has. But we're going to do that not on PowerPoint. We're going to, let's see. Okay, there we go. This is our testing site. Okay, so the first thing, you log in and you come to a search screen. We spent a lot of time developing the search screen based on input from EMTs and emergency medical professionals. What we really wanted was something of a quick search that was not too constrained, a predictive search, kind of like when you go to Google, because EMTs want to use this thing on an iPad or a smartphone. They don't want to have a lot of little fields. They might not have complete information when they get to a scene. So we developed it such that you can type, let's see, Mickey, and we have Mickey Mouse, or you can type backwards. So it does the predictive searching. Every time you type a keystroke, it does an AJAX search of the ePOLST registry and tries to find that patient. And it identifies with name and date of birth. Okay, it's thinking about it. Hopefully it's not this slow in an emergency. Okay, there we go. So this is Mickey Mouse ePOLST document, and the first thing you'll notice is here at the top there's the Star of Life, and the two things that EMTs or emergency people really care about the most are right in your face right when you log in. And they care about code status, attempt to resuscitate or do not attempt to resuscitate. They care about medical care, which is comfort measures only, or what are the other choices on full treatment, comfort measures only. So those are the things that an EMT in the field or an emergency room doctor is going to need to know right away. And those are right there front and center. You'll notice there's a list of all POLST forms. Only one can be active. Deepthi talked about the needs for changing POLST forms and that they can be changed. Patients can change their preferences. So whenever anything on the form is changed, that form becomes inactive and it's replaced by a new active form. And the physician, again, has to go in and sign or certify that active form. You'll notice the QR code. So when we print out a paper POLST form, question?
Yeah, you said that it has to be replaced. But
Right.
Say, okay, don't want to have it.
Oh, we can delete, or not delete it, but inactivate it. A provider can inactivate it. Right. So the forms will stay in the system, but they're either active or they're inactive, and a patient can only have one active POLST at a time. The QR code, when a POLST is keyed into this system and printed out, it will have a QR code on it. And we're also looking at implementing some other things like refrigerator magnets or other things with that code on that can be searched with a smartphone. Like I said, the EMTs in the field, they all have smartphones. A lot of them use iPads or tablet computers, and so they can use that if they find a code and they find either just a QR code, which points to the patient, not to the form. They can find the most recent POLST form if what they're looking at is not the most recent. Or they can use that to uniquely identify a patient. Let's see, the tabs here correspond to all the choices that Deepthi showed on the paper form. I'm not sure that we need to go through all of those. And, okay. So, I don't know how much more to show about the ePOLST registry. Conceptually, when a patient wants a form, we weren't able to get paper out of this entirely because we weren't able to solve the problem of patients electronically signing this thing, especially when they go to their homes. So physicians can electronically sign, and they can do that because they're logged into this system. So the solution we came up with that is that there has to be a signed POLST form for that the patient signs and the physician signs, and that goes into the patient's chart. So when the physician signs the record in the registry, they're attesting to the fact that this paper signed document exists. And I think that's all I have to show on this. I guess we can, question?
The website for it?
The website?
Yes.
It's epolst.utah.gov. There's nothing there right now. If you don't.
There are about 50 patient records, but you need to have it either logged in as Jeffry to log in and look at patient data. And this is something that a patient cannot do by himself. He needs to have a conversation with the provider who will
Yeah.
enter the information.
I think eventually, like the Leaving Well Coalition will have a website with information about this whole POLST paradigm, and it will link to the POLST registry and things like that.
Okay. Why don't you shut the video and then take the last questions after that?
Okay. Let's.
Fire department, paramedics.
The paramedics are here. Thank you so much for all your help and for staying online with me. Thank you.
came in to take her to the doctor's, and I just found her in on the kitchen floor. She's not breathing. I didn't know what else to do.
Peter, she's got no pulse. Go ahead and start CPR.
Check.
Has she been sick?
She wasn't feeling well. That's why we were going to the doctor's this morning.
When was the last time you talked to her?
I talked to her this morning before I came to pick her up.
Okay.
So, what are you guys doing?
She's had a cardiac arrest. We're trying to revive her.
She has a living will, and she has a do not resuscitate order.
Okay. Do you have a copy of it?
I don't. My brother took care of all that information. I have no idea where it could be. None.
Okay.
No idea where
Once
it
we've
is.
started, we have to continue until we can confirm.
Oh my God.
Confirm that she has a DNR order.
This is so hard.
So Jeffrey's going to come in. He's going to have a couple questions for you, and we'll see if she's on the electronic version. Okay.
Jeff, check the electronic registry.
Okay, what's her
Her
name?
name is May. It's M-A-E.
M-A-E.
Wilson.
And what's her date of birth?
Is June 4th, 1930.
May Wilson, June 4th, 1930. She is in the ePOLST registry and she has a do not resuscitate order.
Okay. Peter, stop CPR.
There's no pulse. I'm sorry, but she's died. Sorry.
We understand this is hard. The police are coming. They have to treat this as a crime scene until they can speak to her doctor and confirm that he's willing to sign the death certificate for an attended death.
But you did the right thing in calling 911 and mostly in making sure that she had her wishes known in the electronic registry.
Thank you guys for making this easier for me. Thank you so much.
Go ahead and make your phone call, and we'll stay and help you out as soon as we're done.
I just want to acknowledge the people involved in the projects. And are there any questions?
Yeah. Are the details of so you talked about requiring a new election, for instance, if a patient moves from one care facility to another, is that a state-specific requirement, or is that globally as far as POLST is concerned? And how much of that sort of stuff is state-specific?
So there are only about 15 states that have a POLST paradigm, so there's really no standard. So I'm tempted to say state-specific, but I'm not entirely sure.
Okay.
Even the POLST form that we showed, if you look at the California POLST form, it would be different. I mean, the general information would be there, but they might have more details or less details. So I think it might be state-specific.
And the other thing is the QR code option seems like a really nifty one. I wonder, though, if, for instance, a paramedic walks into a facility, or not paramedic, but suppose something's going on at, for instance, a nursing home, and there's a lot of people there who have POLST, ePOLST forms. It seems like it'd be a good idea to also pop up an image of the
Patient.
the patient.
Yeah, we've heard that before, and so that's something that's on our wish list.
Yeah, have some kind of a facial recognition software to say, oh, this is the first thing you're talking
Yeah.
about.
Because otherwise
Yeah,
it'd be the wrong
yeah,
QR code.
right.
Right. Mm-hmm.
And
Yeah.
right now we are pilot testing it. Jeff had mentioned it. So we have about 50 patients, actual live data from 50 patients. But then we are trying to, fix the issues that we identified and then pilot test it in a few other facilities and then roll it out across the state within a couple of years or so. So we've been writing, we are involved in writing some grants to, as Beacon comes to an end, we are trying to figure out how do we get these funds to support the ePOLST registry. And the way the way it has been programmed is, right now there is really no electronic POLST registry in the US because Oregon is not actually electronic, and so New York might be the closest one to what we have over here, but they haven't really published, so it's hard to find out what they have and how much they have disseminated the registry to. So it's interesting, and we're hoping to get some funds to sustain it.
Have you opened up the communication between New York and here to say get a common ePOLST
true. That's eventually what should happen. You would want to have a consolidated repository across the state. Because what happens right now is if you have a POLST form in California, that's not legally binding in Utah, so you would have to fill out another POLST form. But then since the forms itself are so different, you need to first standardize the paper form and then create this consolidated registry. So there are lots of, this is just a baby step. There's lots more work that needs to be done.
Anything else?
Thank you.
Okay, thank you very
Thanks.
much, both of you. I appreciate that. Nice job. And Jeff's marvelous acting abilities.
Oh,